sound better if I turn the microphone on, wouldn't it? Good afternoon, and I'd like to welcome everybody to today's Health and Wellbeing Board meeting, including everyone present here in the Council Chamber and those who are listening online. Before we begin, for those of us in the Council Chamber, there's no fire drill planned for this afternoon. In the event of the fire alarm sounding, we need to leave the Council Chamber through the rear doors. And that's the only impression I'm going to do of a very elderly air hostess. And then go out into the reception and take and assemble in the car park in the front of the building. Can I please remind everyone to ensure that their mobiles and devices are kept on silent? And also, when invited to speak, can you please ensure that you switch on your microphone? And you'll see with mine, there's the little red light. And then switch your microphone off when you've finished speaking. Otherwise, the officers attending the meeting via Teams and members of the press and public won't be able to hear you. If you wish to ask a question during the course of the meeting, can you please raise your hand, and my Vice Chairman, John, will take note of those wishing to speak. So once again, thank you for all attending. I know that we have a number of apologies, and I think that's a combination of fuel playing quite a major part as well as other things. So Katrina, if you could move on to apologies and replacement members, please.
Thank you, Chairman. Yes, we've received apologies from Councillor Mrs Rawlins, Heather Sandy, Sunhill Hindosha, Elaine Bayliss, Kevin Lockyer, Sarah Fletcher, but we do have Nicola Clark attending on Sarah's behalf today. We've also received apologies from Oliver Newbold and Jason Harwin, but we do have Lee Johnson attending the meeting as an observer on behalf of Jason. Thank you, Chairman.
Thank you, Katrina. We then move on to declarations of members' interest. Do any members have any interest to declare? Take that as a no. We will then move on to item 3, which are minutes of the previous meeting held on the 22nd of June 2021, and confirm that these minutes of these meetings are an accurate record. I don't propose going through them all. However, does anybody have any errors, admissions, or anything else? Take that as a no. And therefore, can I ask for a proposer? Thank you, Councillor Bowkett. And a seconder? Thank you, Councillor Kendrick. We will then move on. Thank you. The minutes are agreed to.
Can we just have a vote on that, Chairman?
Oh, do we have to? Okay. Can we have, if you could just indicate if you are in agreement, would you please raise your hands? Anyone not in agreement? Anyone abstaining? Okay, thank you for that. We move on to agenda item 4, which is the action updates. Again, these are just for noting, and unless you wish to comment on any of these items, no, we will then take them as read. Thank you. Agenda item 5, Chairman's announcements. Again, I don't propose to laboriously read through these. However, I would just like to, because it came too late for printing, could I offer my congratulations to Maz Fosh, who has become the Chief Executive of LCHS. So many congratulations. Yes. Okay, moving on to item 6A, the COVID-19 update. I'm now going to pass over to Professor Derek Ward, Director of Public Health, for the current position as far as COVID-19 is concerned. Thank you, Derek.
Thanks, Councillor Woolley. So the current position, I'll do, as I normally do, the national data that's on the government website, and then I'll give an update on our internal data. As of this morning on the national site, the England rate was 313 per 100,000 population, and the Lincolnshire rate was 344. So not a massive difference between those two. We do continue to see deaths, sadly, from COVID. Nationally, UK-wise, over the past week, there's been just under 1,000 deaths, and in Lincolnshire, over the past week, 7 deaths. But I expect those, sadly, to go up a little bit based on what we're seeing in the data, which I'll come on to. It's worth noting on the national website as well that there are a number of areas around us as Lincolnshire that are having elevated figures. So North Lincolnshire, for example, is 587 at the moment, and that's, I think, in the top 10 or 15. Leicestershire and Northants are both over 520 as well, and that's at a population level, and I'll come on to why in a minute, having just come off a regional meeting. So figures are going up. I think we spoke at the Outbreak Engagement Board a couple of weeks ago that they hadn't gone up, and I was expecting them to. It looks like it's been a bit of a longer delay, more than we've managed to dodge that, unfortunately. The case rate is being very clearly driven by school-based cases. You can see that on the national data, which is about 5-6 days behind. But on our local data, our overall rate in Lincolnshire up to the 25th, so it's 3 days ago, our rate there was 384. So it's definitely going up from 344, but not massively. But if you think 384 for the whole population, our over 60s rate is 219, so it's lower. Our rate in our 4 to 11 year olds, so primary school, 743. The rate in our 12 to 16 year olds, 2,270. So we can see that the rates overall are being driven by secondary age school children and young people, as we sort of expected. Clearly that is the group that have not yet, although we are in the process, and I'm sure we'll come on to it, we are rolling out the vaccine too, but clearly even if we rolled out the vaccine this week, it wouldn't have a significant impact given the time it takes to develop antibodies. Just by way of contrast, the rate in our 18 to 30 year olds, so the next band up if you like, is about 220, 230. So you can see it is quite a concentrated increase in school age children. I would expect that to translate into household transmission, even what we call a breakthrough infection. So somebody, parents who may have had both their doses are still at risk if their child or the young person who they are living with catches it. So really important that people try to minimise contact with anybody who tests positive, and of course anybody who tests positive in that age band, or indeed any age band, and any child or young person who has symptoms of COVID or is actually feeling under the weather, the very clear advice is to please keep that person off school, get them tested to make sure that they're not in the early stages of COVID, so to try to keep on top of infection rates in those age bands. We continue to support our schools through the health protection team in the council. There is Department for Education Helpline as well, and Public Health England are engaged with outbreaks when we see them, but predominantly it's just lots of cases in lots of different schools, as we thought we would see. Somebody else will cover, I'm sure, the hospital situation, but in a nutshell, we are not yet seeing those cases feed through into significant hospital numbers. Fingers crossed that will never happen, on the grounds that the vast majority of children and young people who catch the disease will not have a severe disease. Indeed, somewhere between 40 and 60% of the tests we did when children came back to school, the lateral flow tests, of those who tested positive, between 40 and 60, so at least half, didn't have any symptoms even though they were positive. So it is still very clearly a very mild disease in our children and young people, but we're seeing lots of numbers. in that age group. I think I'll pause there on the assumption that colleagues will cover the NHS position, but happy to chip in.
Thank you, Derek. Andrew, would you be prepared to just comment on the situation in ULHT at the moment?
Certainly, thank you. I was just checking the numbers as you spoke, just trying to get an idea of the timeline on that. So if I go back to the 15th of September, we had 53 COVID inpatients. On the 22nd, so a week later, we had 47, so going down. And just looking at yesterday, it was 37. So I'm sure Derek will tell me that's not a trend. It's just some random numbers, Andrew. But I'd rather they're going in that direction than going in the other direction. So COVID numbers going in the right direction. We have other pressures of other things that drive some of the issues that we've got. Thank you.
Thank you for that, Andrew. Questions, anyone? Okay, Councillor Wright first and then Councillor Kendrick.
Can I just ask for Derek? Obviously, you know, COVID is still a major concern and we're dealing with it. But the next concern now is flu. And we know that people, I had mine yesterday, people are going for their flu jabs. But is flu going to be tracked in a similar way? And are we going to be receiving updates? Because obviously the two are going to be crossing over and it's going to be a concern. And we need to know whether we need to be helping with the comms on that.
I'll do from the public health perspective. I don't know whether NHS colleagues want to cover flu widely. Yes, we will get those data. Very comfortable to report back on those data. I'm sure NHS colleagues can cover the flu vaccination uptake numbers as well, because it's the two things together. So happy to do that here, happy to do that through other mechanisms as well.
Do you want to comment at the moment? Yes, if you come in now, John, and you're not queue jumping, but I think it's a good time to make a comment.
Just to add to Derek's comments, if I could please. Having heard people like Jonathan Van Tam talk about the challenges over the next 6 months, I sense they are as concerned, if not in a sense more concerned, about flu and some other respiratory viruses that are going around as they are around COVID. So it is a really sort of imminent concern for us in the NHS, and we'll certainly be tracking it in a very similar way to as Derek's just described with COVID as well. In terms of the vaccination campaign, that has started in Lincolnshire. So you may be aware that quite a number of our GP practices have commenced their flu vaccination campaign with their population. Others are, not all have got off the blocks yet, but those that haven't are going to be very shortly. There's a few issues with supply and logistics there. But I think you're quite right to highlight it, Richard. It is a real concern for us, and just to assure the board clearly will be keeping a close eye on it, and very happy to provide updates to the board and on other occasions as well as you feel appropriate.
Thank you. Can you turn your mic off? Councillor Kendrick.
Thank you, Chairman. It's a question for Andrew, actually. I saw a report that the majority of people who were hospitalised with COVID had not been fully vaccinated. I don't know if that's the true case in ULHT as well.
Thank you, Councillor Kendrick. You may remember we talked about this in the summer. At that point, it was predominantly, well, it wasn't predominantly, it was more people who hadn't been vaccinated were ending up in hospital. As the rates have grown and continue to stay high, it's purely a numbers argument. So what we're seeing now is, of the numbers that Andrew said, so 37 confirmed cases in ULH as of 8 a.m. yesterday. Of those, 24 of the 37 had 2 doses of vaccine. But what we've got to recognise is that roughly, I'll look at John here, 9 out of 10 people, adults in Lincolnshire, have had one dose at least. And in a lot of our sort of 30 and above age bands, it's that sort of figure for 2 doses. You're talking about the vast majority of people have had doses and probably some sort of exposure immunity. So we would expect the majority of people in hospital with COVID to be those who have had it, because just it's a numbers game. If 9 out of 10 people have had a dose, but 1/3 in hospital haven't had any doses, you can see that the risk to you of ending up in hospital if you haven't had your vaccines is higher than it is if you have had your vaccines, notwithstanding that we know COVID generally attacks people who are more susceptible, older age bands. So the basic message is get your vaccine because it will protect you.
Councillor Bradwell.
Sorry, Chairman, I'd forgotten how to use my microphone. I've only been here years. I thought I'd put it on to tell you I wanted to speak. Never mind, I'm getting old. Yeah, I just wanted to go back to schools, because I know a couple of teachers, and what they're saying is, and maybe we need to send something out to schools, I think about washing hands, and, you know, just generally those, I know you used to always say it, hands, face, space, have been lost. And I mean, it isn't just students actually that got COVID in schools, it's teachers as well, you know. So I do think that, you know, I know initially when we were all wearing masks and that, and probably that was keeping everything under control, we were socially distancing as well, and we're not doing that now. But I do think there is something about, you know, schools trying to, and it's very difficult with teenagers, I know, but, you know, getting young people to think about things like that, because, you know, we have got to try and keep schools open. You know, nobody wants to see schools closed again, but actually, you know, the rate that things are increasing, it is a bit worrying, and they haven't been back very long.
Derek.
I completely agree with you, Councillor Bradwell, and happy to draft something to go out. We are working with schools on a day-by-day basis through the health protection team, given all of that sort of advice. I think it's worth noting that hands, face, space, okay, face coverings are not routinely used in schools, although we are working with some schools and some year groups that are wearing face coverings because they've got particularly high rates, and the school thinks that's the right thing to do, and we're very supportive of that where you meet that sort of threshold, because we want to keep children and young people in school, absolutely, but we want to try and minimise the risk, and it's really quite a difficult thing to get the balance right, because the vaccine program's just rolling out now. I think the other point I wanted to make is that we generally think that with COVID, schools haven't driven rates up until this point. It's been external infection that has been brought into schools. Now, because really those age groups are the last age groups to get the vaccine, they are going to drive infection. Whether that spills over into the general population, we will have to keep a close eye on. And those numbers at the moment, in terms of different age bands, would suggest we're not seeing big numbers in age bands outside of school age yet, but of course we've got 10, 11,000 students, university students coming back, so we'll need to keep a close eye on that. The other bit though is that we do know, and there's a really strong evidence base, that flu outbreaks and epidemics are driven by school age children, and so hands, face, space, basic infection prevention control mechanisms will help to protect, as well as the nasal vaccination program that we are delivering in schools will help to protect children and young people in schools, teachers and the general population from flu. So I think there might be something there we'd want to join all of that up and say washing your hands, keeping your distance, being outdoors is a really good idea for as long as you can through the autumn and winter.
Councillor Marfleet.
Thank you. I took my daughter to a university and there was 14 people on each floor, perhaps 6 to 8 floors high. Went to the loo, no soap, no hand towels, no nothing. Can you think, actually, in this modern day and age where they can't even wash their hands after they've been to the toilet, and with COVID, actually I was quite appalled, and I actually complained, and the woman just said, well, I think it's all right. And she said, well, what you do is you take your towel and the soap to it. And I'm thinking, well, what about everyone else? So it does make you actually sometimes think how many actually of these sort of places do have the facilities in. That was a decent university.
Councillor Wright.
Thanks, Chairman. It's on this same point. If we're giving messages to schools, you know, and expecting them to comply, or universities. This morning after my daily swim, I visited a well-known supermarket at the north of Sleaford to see lots of students buying their healthy biscuits and sweets and chocolate, and all stood in gaggles inside the supermarket. I mean, there was a group of 10 all together. They could all be separated by the time they get to school, but the fact is they've all just cross-contaminated in. I nearly said it was Tesco's then by mistake. They could, you know, by the time they finish doing the supermarket shopping, it's too late. So, you know, if we can, messages should be going out to places like that. If they want to encourage them in to keep the profits going, then they should be thinking about the actions of what they're doing as well. But I probably, in the time I was in there, I saw in excess of 50 school children, and most of them were stood in groups.
I'm going to go first, Derek, because I want to add to that in spades. It's my biggest gripe at the moment, in that I don't feel that the message, supermarkets in particular, not only do they appear to not bother quite so much now with the hand sanitizer and the trolley sanitizer, regardless of whether whatever the science says, it's the discipline, and it comes back to your point. But I don't think it's just students. I think it's all age groups. You go into any supermarket and there is the majority of people not wearing a mask as opposed to who are. And again, I would say it's the discipline of doing certain things. Because I'm going to come back to you, Derek, but also we've talked about schools, but I certainly have a personal interest and concern. The number of small, tiny children under 2 that are really picking up some absolutely horrible viruses and being hospitalised. I mean, we've recently had one of our colleagues have a grandchild with the most horrendous experience through a virus, but they're not isolated. There's a number of them, and it's a case of they're obviously mixing in nurseries and preschool, or whatever you want to call it. It's getting that message out in a way that they too can make sure hands, face, space, but obviously with tiddly tots and nursery, that's nigh on impossible.
It was only a suggestion, Councillor Woolley, which is that the Lincolnshire Outbreak Engagement Board, one of its key functions is to lead on the communication side, and I wonder whether this is something that could be done jointly through that mechanism around the going back to basics, almost, you know, hands, face, space. We're not going to be standing outside as we get to November, December, January, but that doesn't mean you can't keep your 2 metres. It doesn't mean you can't wear a face covering, and certainly should be washing your hands and carrying around some hand gel. All of those things are really easy to do, and I agree. I think the message has got a little bit lost, and whilst we can't influence national government, we can do that for Lincolnshire, and I think it'd be a really good thing to do.
Thank you for that. Okay, if that's all the questions on this paper, thank you for your update, Derek. Okay, we will now move on to item 6B, which is the integrated care system. And thank you, John. You have a report on this.
Thank you, Sue. You'll see it at item 6B. There's a brief cover paper plus a series of slides. I'll not walk you through them sort of slide by slide, but I'll try and pull out all of the sort of salient points about where we are with the integrated care system update. But just prior to that, just building on the previous conversation, could I just emphasise to Health and Wellbeing Board, I think you're all very aware of this, that the NHS in the county and indeed in the country today, and certainly over the next 6 months, is dealing with an exceptional level of demand. I think you'll be aware that urgent and emergency care demand, whether it's through GP services, community services, A&E, ambulance services, are very significant. And clearly we've got targets to meet around cancer patients, catch up our people who need their operations. We've talked previously about mental health concerns and so on. Plus, of course, we've got the booster campaign, the flu campaign, and so on. So the changes that we're going into in terms of the integrated care system in Lincolnshire, like other systems across the whole of the country, are in the context of undoubtedly the most significant challenged operational times that the NHS has ever been under. So the key points, I think, just to update the board on, are that, as reported last time, the government is taking legislation through Parliament to create statutory integrated care systems in the 42 geographies that make up England, and Lincolnshire is one of those 42 geographies. The intention is that the legislation will be complete and passed to enable these new statutory changes to come in with effect from the 1st of April next year, i.e. just over 6 months' time. So we've got a lot of work to do in terms of preparing for us to get our integrated care system in Lincolnshire in terms of the statutory arrangements off the ground safely and legally. The two key sort of component parts really of an integrated care system consist of an integrated care partnership, which is a joint partnership between local government, the NHS and key partners, broadly about the understanding and the strategy around health and well-being in the population. And as we've previously considered, the Health and Wellbeing Board in Lincolnshire is exceptionally well placed to take that forward here in Lincolnshire. As I understand it, I think we're only one of, 3 patches in the whole of England where there's only one Health and Wellbeing Board for the ICS. I think the others from memory are Somerset and Gloucestershire. So everywhere else has 2, all the other geographies have either 2 or more Health and Wellbeing Boards. So I think that's to our advantage. And the second component is the NHS Integrated Care Board. So in our statutory integrated care system in Lincolnshire, this integrated care partnership and the NHS Integrated Care Board are going to be the 2 sort of key features that together make up the statutory integrated care system. I think, as I've previously mentioned, the integrated care systems have 4 core purposes about improving health and outcomes for health, reducing health inequalities, improving productivity and value for money, and adding social and economic value. Just in terms of what's coming out or has come out and is coming out from national bodies, NHS England Improvement have recently published 2 suites of guidance, and it's voluminous. That's now in the public domain. Lots of subjects are covered in that guidance, and it's hinted at in the presentation. And I understand that there's a third bit of that suite of guidance that's going to be coming out quite soon. So there's a lot of bedtime reading to get through with all of that. There is a lot of it. Kind of separate to that, a specific additional piece of guidance has been developed, which was published just a couple of weeks ago on the establishment of integrated care partnerships. For us, as we said earlier, that's hopefully going to be a fairly straightforward task as we just evolve the Health and Wellbeing Board forward. I must say that guidance has been developed, I understand, with input from the Local Government Association as well as NHSEI. That's been published by the Department of Health and Social Care. I've been through it a few times, and I think we've just got a bit of work to do to work out how we're going to translate and adapt that into our system here in Lincolnshire. It does raise more questions than answers in lots of ways. And I think, Chair, one of the tasks that we do need to attend to before we meet again as a Health and Wellbeing Board is actually to have a pretty fundamental look at that guidance and work through how we do want to evolve our sort of terms and of reference, say terms and conditions, terms of reference forward. What seems clear is that a Health and Wellbeing Board technically cannot be an integrated care partnership, but I think there's some sensible workarounds that we could probably put in place around that. So I think that's a key piece of work for this board. Other things just to share with you is that there is a team, an executive team, we call ourselves the Better Lives Lincolnshire executive team, which sort of has executive leadership of how we're developing our integrated care system, and that's co-chaired by Debbie Barnes and myself. As part of the establishment of the NHS Integrated Care Board, the NHS Lincolnshire CCG, subject to the passage of the legislation, will cease to be come midnight on the 31st of March next year, and all of our sort of functions and our resources and our staff will then transfer into the new statutory body. So if you like, internally in the CCG, just closing the CCG down in a appropriate sort of legal, safe, effective way, whilst at the same time building up the NHS Integrated Care Board, whilst at the same time attending to the significant operational pressures that we have, means it's going to be a pretty sort of crowded space, I think, for us over the next 6 months. The NHS ICB chair role has been advertised, and there has been a process with that. We await the outcome of that. The NHS ICB chief executive role, applications for that closed at midnight, or 1 minute to midnight on Sunday, and clearly there'll be a process for that going forward, as there will be for all systems across the country. And then following those roles being filled, then obviously building up the board with the non-executive directors, the executives and the partner members will be a key task. And you may be aware that one of the 3 partner members will be a local government representative. So as well as, if you like, the Health and Wellbeing Board and the Integrated Care Partnership being a collaborative effort between the NHS, local government and colleagues, we're trying to reciprocate that in the NHS Integrated Care Board as well. And of course the challenge will be keeping all this simple. It's easy to make it complex, but we need to keep it simple. We need to effect the changes in a safe and legal way. We do need to focus on the operational demands that the service is under. So the sort of steer we've had regionally and nationally, which is very welcome, is that we need to take what's been called a de minimis approach to putting in these statutory changes to make sure that as much of our time and energy as possible is focused on supporting the service day in, day out. I must say de minimis is still very significant. But we've just got to arrive on the 1st of April in a safe and legal way, and then we can sort of build things forward from there. So I'll pause there. Hopefully I've covered all the key points that are in the slide deck. Happy to take any questions or comments. And again, I think for us, the key piece of work we need to do is to take this integrated care partnership guidance that's been issued and put that into a proposal for how we work in Lincolnshire that makes sense to us. Thank you.
Thanks, John. Before I bring anyone else in, I think obviously we knew that when we were trying to put something together, there would be bumps, and probably the guidance on the partnership may be a little bit of a bump, but I'm reminded of the lead, the NHS lead nationally for the integrated care system, who said, and I've got it written down on a piece of paper somewhere because I was determined not to lose it, with his name against it, that the NHS wanted to be as flexible as possible. And I think the key for all of us is that, yes, of course, we will work with anyone, but we've got to make this first and foremost work for our residents in Lincolnshire. And if it doesn't, well, we will find a way of getting that outcome, but it might be a bit different to the prescribed guidance in whatever tome that it might be. But we will, as we always do, find a way of working through that. So just an interesting point at the moment, isn't it? But as I say, we will get through it. Questions? Any? Councillor Cook.
Thank you, Madam Chairman. Just expanding on the point you've just raised, actually, about working for residents. Obviously, in the south of the county, obviously in Stamford, we border, I think it's 3 other, or what will be ICSs. So what will the partnership working look like for residents in the south of the county, particularly because of, you know, the geography of the area? Because I think in terms of, we wouldn't want to see people be travelling from, let's say, Stamford to Boston for services they could easily access 10 miles away in Peterborough. And that's sort of the point that you were expanding on, Chairman, which is, you know, about making it as easy and accessible as possible. So I suppose it's how will we as an ICS in Lincolnshire work with the others, and what sort of role will that look like?
That's a great question. Of course, Lincolnshire, we're a vast geography, aren't we? And so many of our population actually either at the south of the county, I mean, something like, 140,000 people in the south of the county look more to Peterborough than anywhere else. We've got our population out towards Long Sutton, who looks towards Kings Lynn. Obviously on the western sort of fringes of the county, people look more into Nottinghamshire, and the north of the county up to North Lincolnshire and Goole. And I think that one of the dangers we need to be alert to is that if we think of Lincolnshire as a system, that doesn't mean we're trying to hermetically seal ourselves in from all of our neighbours. So having really strong and effective working relationships with our neighbours is vitally important. So that means that we already have, as well as we will continue to have, really sort of strong, effective partnership arrangements with particularly the hospitals out of county that our residents need to access. So we don't envisage in any way changing, cutting across people's rights to go to the hospitals that are most convenient for them, that are closest to them, and which, quite frankly, they've been to for many a long year and will continue to. So there's nothing in the integrated care system that's going to cut across that sort of patient flow. And again, just talking about Northwest Anglia Foundation Trust, clearly they actually run the hospital in Stamford. And we have great relationships with them. So I don't see any significant sort of disturbance to that. I think the difference we're actually trying to make with all this is about joined up, proactive health and care in the local community. So I think what I'd expect to see in and around Stamford, and indeed across the rest of the county, is far more sort of cohesion and integration between all aspects of the NHS, but also with our colleagues in social care, whether it's adult or children, the third sector, the care sector, so that people in our local communities get far more integrated care locally than is sometimes the case now. And I think the real point of the integrated care system isn't really to have a system, it's to have integrated care, and the focus of that has to be in our local communities. And as I observe, where we are across the county, there's a lot of great stuff going on already across Lincolnshire. So we've got a lot we can build on. So very happy to confirm we're not looking, just by dint of having an integrated care system, to interfere with natural patient flows, which are nearly all out of the county. Very few patients from out of county come into Lincolnshire. Thank you, Callum.
Thank you, John. Any other questions? Councillor Marfleet and then Councillor Wright.
Thank you. I mean, when you actually read through the document, it is very light, easy reading, and actually does make good sense. Although I would agree that when you sort of look at the board itself, it is a light selection. And, Stamford was mentioned, but I know the north, northeast Lincolnshire. I mean, Halton-Nicklay is like becoming a sort of a large urban area on the end, and people get sent to Grantham because it's within our area and get blocked from Grimsby, which is a mile away. And and it's like, you always hear of the issues. It's like, oh, I went to Grimsby, you should have gone to Lincoln, you went the wrong way. And it doesn't quite connect. And I think there is merit that, and hopefully in the future, the board itself will have some connections with those other areas of northeast links and Peterborough, and also I suppose you've got King's Lynn if you get right round on the other side, because without them, we will never get really good integrated care, because it's so, we're encaptured, aren't we, by the Wash and the Humber. But I think, that was the sort of thing. And I suppose the only other thing which sort of came in was sort of capitalising on some of the, when you go through it, the likes of procurement and sort of those areas that sort of, like commissioning of services, it does sort of touch into that zone. But I know as like the council and the fact we do commission the volume of services, especially in adults and things, that there is benefits for that into other partnership organisations throughout Lincolnshire. I would hope that it, looking at it, it looks a bit like the CCG is going to sort of evolve into this. I don't know quite how easy that is for you guys to implement, but you've been used to it before. It's not the first time we haven't sort of evolved our sort of health into a new dimension, which is still part of the old dimension. Thank you.
Thank you, John.
Yes, some great comments. I think I think you're right when you, without diving into all of the details of the guidance, the sort of guiding principles are really very much common sense. And you'll recall in 2019 we had a sort of public engagement exercise, Healthy Conversation, and actually what a lot of people said to us is we want integrated care, we want it joined up, we want it based locally in our communities. I think the challenge for us is how do we make that happen? So 2 little sort of anecdotes from me. I actually went to one of our district councils, again, about 18 months ago, so this was pre-pandemic. I described a scenario where the public may think that the NHS and social care and the third sector is all joined up. But when you think about, we've got our GPs, we've got our community nurses, we might have a community hospital, we've got our mental health teams, we've got our adult social care, we've got our children's social care, we've then got the third sector, we've got, you know, the care homes and then the domiciliary care. You'll see how it isn't joined up, and the challenge is about how we join that up. And then we had at least a half hour, if not 45-minute conversation about them telling me, no, we all know it's not joined up. And lots of examples of where patient care, or just looking for health advice or support or something, was far more complex than it needed to be, because people were being bumped from one service to another, or one bit of advice to another, didn't know where to go, and so that plea for, you know, simplicity and joining up locally was that point was made very clearly to me in that meeting. And another conversation I had with a patient who had a chronic disease. He said, if I'm at a car accident, I expect you to pick me up, take me to hospital, sort me out and get me home safely, please. But I've got a chronic disease, so really what I want from the NHS is for you to help me manage it successfully so I can get on with the rest of my life. And I took a lot from that as well. So there's something about that combination of integrating care locally and supporting people to live with and enjoy as best health they possibly can. And I think that's at the heart of it for me. I think that if we're going to make a success of this integrated care system, for me, there are sort of 3 key sort of partners, isn't the right terminology, but that we've got to work differently with as the NHS. One is local government, and I think we're doing a lot of great work, and we have been doing for quite a while here, but I think we can go further and faster with that, both districts and the county council. The second is actually our clinicians and our clinical leaders. We've got a lot of work to do internally with listening to and allowing our clinicians to really have their voices heard in how we design and take our services forward. And the third, and arguably by far and away the most important sort of constituency, is all of the communities that we serve across the county. We know, don't we, how different Mablethorpe is to Stamford, and Long Sutton is to Gainsborough, and all points in between. And I think a really important challenge for us is having this integrated care system really sort of centred in local communities across the county, rather than just doing it on some sort of county-wide thing. And I certainly will be looking for some advice and guidance and support from the county council, from district councils and others, just in terms of how we can best make that happen. And the final point is, yes, we're used to lots of statutory changes in the CCG world, and clearly as the CCG's functions and our staff move into this new arrangement, we've got to make sure that there's a safe and effective transfer. But equally, the point is that this has got to be a new venture for us. It's only about once every 10 years the government takes legislation on the NHS through Parliament, and they're not doing it so we can keep everything the same, but just with a different title on it. So I think we've really got to scope out what do we want to be different about the integrated care system in Lincolnshire. And there's quite a bit in the guidance in terms of what the sorts of things they're looking for. But again, I think that's going to be a co-designed piece of work that we can get into through the winter, and no doubt as part of the first year of our integrated care system. Thank you, Sue.
Thank you, John. And sounding like a broken record, that's why I truly believe we need a Lincolnshire model for Lincolnshire. So I will be pushing for that, and I hope you will be joining me as well. But having said that, I mean, we work very closely together. We iron out as much as we can to make sure that we've got a smooth process, but we've got a much further that we can go, but that's, fortunately, we're on the front foot from the point of view of wanting to do it. I think it gets very difficult when you've got areas that we're lucky we've got that coterminosity. It's much easier for us than it is elsewhere. And when I listen to colleagues in different councils around the country, I realise just how lucky we are, and also how much further forward we are, actually. I turn around, want to beat myself up, thinking, oh, we should be doing more, we should be doing more. But when you do actually listen, you find that actually we're where we need to be as far as our county is concerned and our residents are concerned. Councillor Wright.
Thank you, Sue. Hopefully an easier question, John. I think you said that the amount of guidance and documentation out there was voluminous, so I've been reading through War and Peace myself and couldn't answer this question from my district colleagues, but they've asked with regards to the ICB and the recruitment of the chair role, then is it laid down anywhere what that process is and what the terms of reference is going forward?
Yes, the chair role was nationally advertised. These are, so of the 42 systems in the country, nationally they deemed that the chairs in 25 of those had been fairly recently put in place, and they effectively have then now appointed those 25 to the ICBs going forward. Of the remaining 17, of which Lincolnshire was one, where for one reason or another there wasn't an independent chair in place, they've been through a national exercise in terms of a recruitment campaign, interview process, and so on and so forth. And we're currently waiting the outcome from that. So it's been handled in line with all the standards you'd expect in terms of public appointments, and that obviously will need to be the case for the chief executive role as well. Hopefully that answers the
terms of reference. Is there a terms of reference?
Yeah, there's a sort of job description. There's quite a pack that was put out. I'm happy to make it available. It's a publicly available document if that would help.
Yeah, I couldn't find it. I was asked and I thought I couldn't find it. But then again, there's that much to read on this that it's near on impossible trying to find what you really want to find.
Okay.
Thank you, John. Glenn.
Thank you, Chair. A couple of observations, if I may. The first is that the Health and Social Care White Paper, the ICS conversation that we're having, is only part of a picture. There's a real danger of diving too deeply into some of the detail when it's actually directions of travel, arguably, that's more relevant to us at a strategic level. Later this year, the government will publish an integration white paper, ostensibly targeted more at local government, as the Health and Social Care White Paper is targeted at the NHS. That's the first thing to bear in mind. When the Minister announced the Integration White Paper, he did say later this year, but that could mean March, it could be November, I don't know. What I do believe, though, is that it is expected to be quite ambitious, so not tinkering at the edges. I think the second thing to bear in mind is there's a possible interpretation of some of the things that John has said, which overall I absolutely agree with. And it is, I think, a fair point that the Health and Social Care White Paper was largely about reintegrating a dispersed NHS. However, in other sectors, diversity is a strength. If you take the environmental analogy, we have over 5,000 voluntary sector organisations and community groups. Emma probably will correct me if I've got that wrong. Over 280 social care providers. It also means we avoid monopolistic tendencies in a market that is actually quite vibrant despite the challenges it's facing. I think the trick for us is to find a vehicle for allowing those diverse sectors to have a strong voice at macro levels. Thank you, Chair.
Thank you, Glenn. Any other questions? No? Okay, thank you. In that case, can we go to the action required, which is to note the current position in relation to the ICS legislation? Everyone happy with that? Take that as a yes. Thank you. We will now move on to item 6C, which is the Lincolnshire Mental Health Service. Sarah, I understand that you are going to give us a presentation, so the floor is yours. Thank you.
There we go, I can see the light now, thank you. Thank you, Chair. So I was going to do some slides, but I think the computer said no. So I'm just going to talk through the slides that people have got in their pack, and I'll just give a nod in terms of the page references. So,
sorry, before you get started, is there anyone that hasn't got a pack of the slides? Okay, that's great. Everybody's organised. Brilliant.
got full house, thank you. So I'm Sarah Connery, I'm Chief Executive of Lincolnshire Partnership Foundation Trust. So this is a bit of a situation report really in terms of mental health services in Lincolnshire. There's been a lot in the media around demand for secondary mental health care services through the COVID pandemic and beyond. So I thought it was opportune to sort of bring here a bit of a situation report on where we are in Lincolnshire, and happy to take questions at the end. So you'll see on page 36, I'm not expecting you to be able to read the heat map, which is there on the slide deck there, but just so colleagues are aware, we've been tracking referrals to our services very closely since the start of the pandemic. And that heat map there to the right of the slide just shows where it's sort of orange or bright red, where we've had consistent and significant increases in referrals to our services. So basically, an impact where you can't just pull it back the following month or pull it back through discretionary goodwill of staff working extra hours in terms of keeping to our waiting list targets. So what we've done is we've pulled out those areas which have seen that significant and prolonged increases, and they're listed there on that slide. So basically, crisis services, we are still just hitting our 4-hour response target that we have for crisis intervention. But as a result of the impacts we're seeing, not just in LPFT, but also our police colleagues, ambulance services, and also at ULHT as well, we've instigated a full system review of crisis services, which we're hoping to complete by the end of December. In terms of any gaps that need filling, best practice, benchmarking with other services to ensure that we've got enough capacity in the system to meet that increasing demand. Early intervention in psychosis, the data in that table there goes up to June, and recently we've seen that decrease, so I won't labour that point. Perinatal mental health, we work to a 4-week waiting target for perinatal mental health services, and we've had agreement from commissioners to increase investment into that service as part of the long-term plan. And it is actually an increasing access target where we're actually expected to see an increase in access to those services as we increase our offer across the county. Sexual assault services, we've seen a marked increase in referrals to those services, but also sadly an increase in the delay from report to court as well because of the impact of COVID services on the court system. So we've been talking to other systems as well, and this isn't just a Lincolnshire problem, this is pretty much across the country. But it is impacting on the ability of the staff to be able to provide a good service for the victims of sexual assault. Something that's been quite broadly covered in the media is children and young people mental health, particularly eating disorders. We have a 6-week target for core children and young people service, and we're currently not been able to meet that consistently. So we're about 3/4 hitting the target for our 6-week target. We have got additional investment that's been agreed to go into those services. Recruitment is underway, and we're hopeful that we'll be able to have the services up and running through the winter to ensure we're able to cope with that increasing demand. Interestingly as well, we're seeing an increase in adult eating disorders and also older adult eating disorders. So some presentations that we haven't seen pre-pandemic. Again, this is something that's being seen across the country, not just in Lincolnshire. And interestingly, autism diagnosis, we've had a significant increase in the number of referrals coming through for autism diagnosis. And it's quite a high conversion rate from referral to diagnosis of autism, so in the high 90s. So these are all appropriate referrals that are coming through. So hopefully that gives a bit of a flavour in terms of where we are in terms of increasing demand. And this is at a time where we've got capacity issues due to infection prevention control measures. So we have had to take beds out of capacity. We've also obviously had staff isolating or actually off sick with COVID as well over this period of time. So the staff do work exceptionally hard to try and make sure that we're always providing as good a service as we can within the limited resources that we have. But we are now seeing waiting times expanding. So if you go to page 37, I wanted to take some time to talk about what we're actually doing as a system to transform services and expand to meet that increasing demand. A key game changer for us has been the introduction of 2 24-hour, 7-day-a-week mental health helplines. And we have one for adults and one for children and young people. And there's some statistics there in terms of sort of the average calls a month that we're getting. You can see for children and young people, it's about 243 calls a month. And for adults, about 700 calls a month. So it is a well-used service. And we do whatever we can to get it out there in terms of our communications channels. And we're doing a really big push this month. It's World Mental Health Day on the 10th of October, just a date for your diaries. So we will be really pushing these through our comms channels. A key point for Lincolnshire as a system that's always had quite low bed capacity is to make sure that we've got the right bed capacity in the right place. And as a result of this, we worked with our CCG colleagues to open 15 additional female acute ward in Sleaford, which has enabled us to bring back out of area females who previously have been travelling for quite a few hundred miles to get their care. So that's a really positive news story for Lincolnshire. We've also taken one of our long stay rehab wards and turned it into a reablement focused ward with a 28-day focused short stay where we really invest in ensuring that people have got supported living, occupational health to get people on their feet before discharge. Where appropriate, we've also taken beds out of the system. So older adults, for example, when Grantham turned into a green site at the beginning of COVID, we did close one of our dementia wards out in Grantham. But in every crisis, we have opportunity, and we've been able to reinvest that money under a pilot basis into a dementia home treatment team. So rather than having 18 beds, we're able to offer service to over 100 people. There's community transformation on there, but I'll come on to that under a specific slide. So if you go to page 38, basically there's just some quotes there from people who've used the mental health helpline. So it is making a real positive difference to people's lives. Sorry. If you go to slide 39, so this is a focus on our community mental health transformation. Excuse me. So Lincolnshire successfully bid as a system to be one of the pilot sites for community mental health transformation. We were only one of 12 that was successful. So it was an initial 7 million of investment over 2 years. And we're building it up over the next coming years as we sort of roll out and build on those pilots to make sure we don't want a postcode lottery across Lincolnshire. We want to make sure that everybody's got access to those services. The key point about the transformation is no wrong door, no cliff edges, really hooking up with the voluntary community and social enterprise sector as well to make sure that it's invested and it's sustainable and it's connected through primary care as well as secondary mental health care. So a real important piece of partnership working across all of those sectors. And a key part of this is to have mental health workers embedded in those GP practices, which we're out to recruitment for already. if I just take you on to page 40. We continue to come together as a system to support the mental well-being of our people, our staff, as well as our service users across the county. So we've come together as a system to make sure that we've got a very broad offer open to all, and by all I mean all health and care employees, not just NHS staff there. A key reason for us for sickness absence across all providers is anxiety and depression. So we've put in some real focused staff wellbeing support and a speedy referral through to talking therapies for those staff that need it. We really do, as we head into what will be a very tricky winter, keep our people well at work as much as we possibly can. I just ask you to turn to page 41. So in terms of system working and governance, we have our Mental Health, Learning Disability and Autism Partnership Group, and this is a real key forum for us. So we have police colleagues, district councils, primary care, the local authority, voluntary sector colleagues, as well as all the providers and NHS England and Improvement. And it's a bit of a meeting of the willing at the minute to connect our data, connect our assets, and connect our people around some key priorities for delivery. I think there is something for us in terms of taking this forward if that group is to have some really being held to account for meeting our priorities going forward, and the group is in the process at the minute of building what 3-year priorities might be in terms of reducing health inequalities and improving health outcomes, with a real focus on prevention, suicide prevention, and using our data and connecting it in an intelligent way to make sure that we're using the limited resources that we have as effectively as possible. So that was my slide deck. I'll stop there and I'm happy to take questions if anybody's got any. Thank you.
Lovely, thank you, Sarah. Thanks very much for that. The chair's had to depart the scene for what I hope is going to be a happy family event. I think in the hands of your services, Andrew. So she's left me to try and string this meeting together for the rest of the session. So who wanted to come in? Nicola, were you looking to come in, please?
Yes, please. Thank you. Just 2 questions, if I may, please, Sarah. First one is around the mental health helpline. I'm just wondering how much work has been done around looking at return callers and unique callers and contacts to that line, and what work has been done with that particular community to support them in the community if it's needed. And the second one really is around really great to see the staff hub and all the work that's been put into them. So I wonder if you can give us an overview on the recruitment and vacancy rates at the moment for the Trust, and how that might be impacting on some of those significant areas where you've highlighted that there's challenges for the system. Thank you.
Thank you. Yeah, really great question. So what we've seen from an analysis of the data is that the adult helpline sees a significant amount of repeat callers. So in terms of the, we're doing a proper service evaluation of the helpline and really pulling that through. So I can't give any specific statistics at the minute, but from early analysis, definitely on the adult helpline, we're seeing it's a significant crutch, I think, for a certain proportion of the population. And then the output of that evaluation will be, well, why is it that you're needing to call the helpline? What are you not getting from your community assets in terms of that support? In terms of our vacancy rates, it is significant in terms of consultants and nursing vacancies. So qualified nursing, we're running at around 20% on both of those. So we're trying to be quite innovative in terms of our approach, because the usual methods of just going to NHS jobs just aren't cutting it anymore. So we're working with Health Education England around international recruitment. We're really investing in our own grow your own in terms of the pipeline. So working really closely with the University of Lincoln around apprentice schemes and nursing degrees. We're also working across the East Midlands, because what we seem to find is it's been great with a long-term plan that we've had the additional investment, but the risk is that we start just stealing staff off each other, because there's only so many qualified nurses to go round. So we're working together around a competency framework where it isn't necessarily just the same qualified nurses. What is it that we actually want these staff to do on these wards and in these community services? Can we build a competency framework and look at really as an entry-level position as well, so to build that capacity. Particularly, we're struggling to recruit to inpatient wards, it seems to be. There's some really great, as a result of the community transformation, there's some really interesting new roles that are coming out. And for people who are qualified, it's becoming a really great development opportunity. So there's some work for us to do to ensure that inpatient staffing is still a role that people are interested in doing. So, but it is a real challenge, particularly in Lincolnshire. I hope that answers your questions. Thank you.
Thank you, Sarah. So I've got Councillor Kendrick and Councillor Bowkett and Councillor Bradwell, please.
Thank you, Chairman. I think my questions probably mostly are answered. It was about staffing levels, because I understand there is quite a heavy reliance on bank staff in the case of nursing, and unfortunately you're low on some medical staff as well, and that seems to be a big problem, getting medical staff, particularly doctors. How are you addressing that last bit? Because I know you're relying very heavily on locums at the moment. Thank you, Chairman.
Yeah, thank you. So again, we're looking at international recruitment as a way of being able to increase our consultant base. We're also investing in new roles. So we've got a development associate specialist post, which is the first in the country, the first trust in the country to sort of pilot this role, which is where we can't recruit consultant posts for certain hard to recruit to. Really looking at what the job entails in terms of ensuring our very limited specialist staff are working on the really difficult acute cases, and we've got development associate specialists who are able to pick up some of the other work, and also investing in non-medical prescribers as well. So trying to think sort of a bit more innovatively about how we use the capacity for areas where we can actually recruit. But we do track very closely in terms of our locum spend, and what we try to do is ensure that we've got some sustainability in terms of the locums who are working, so they're on longer contracts rather than people who are in for a day, don't know the services, don't know the work wards, don't know the policies and procedures, because that's when you start to see a real impact on quality. So we do tend to have people engaged on a longer term basis, but yeah, trying every avenue that we can. What we can't have is a bit of a price war that can sometimes go on, where different systems will start to sort of put recruitment and retention premium on, and before you know it, we can't afford the workforce. So yeah, hope that answers your question.
Councillor Bowkett, Wendy.
Thanks, John. Well, Sarah, as you know, it'll be crisis teams for me and aftercare. In the East Coast, as we know, we don't have the community teams that we do need. We're the last on the agenda to get them. As we've discussed before, it's not when you're just in crisis, it's when you're coming out of hospital. That aftercare isn't there. There is no counselling. There's nobody. After a month, you're just discharged. And as you know, we've discussed this, but we do need to look at that intently to get that right. It's good that we're looking at mental health workers in GP practices. It's been one of my gripes that you know someone that you can go to talk to who understands you. And the dementia home treatment team, I'd be look to see more of that. The pilot scheme, I'd be very interested to see that. Thank you.
Okay, thank you. So in terms of the East Coast, it's one of the pilot sites for the Community Transformation Programme is actually the Boston area. So as you say, there is a bit of a postcode lottery that's going on at the minute in terms of the transformation, but as the resource builds and recruitment builds, it will be across the whole of Lincolnshire. But what we're looking at doing is, in terms of the dormitory ward capital funding that we've had, which is going to be a replacement for Ward 12, we'll be looking at making it more of a community and crisis hub on the Norton Lee site, and really having that as a bit of a centre of excellence as well. We've been discussing with police colleagues as well in terms of what's impacting on their capacity in terms of some services sometimes being a bit Lincoln-centric and more time being taken on conveyance rather than actual care. So that is something that we're picking up as part of the crisis review. In terms of the dementia home treatment, I'd be really happy to bring something back to this group too, in terms of the service evaluation. Once we've completed that, because we are still in pilot phase at the minute.
Councillor Bradwell. Tricia.
Well, mine was similar vein. I think community mental health services are dire. I really do. You know, and when you get into the community mental health service, you know, you might see somebody, but then for me it's a follow-up, because those people, just because you've been to see someone doesn't mean, you know, you're okay. So I think all that community support, I mean, it's like with all services, you know, when you're intensively supporting people, that's very expensive, but people don't always need that. They just need the contact, and once, you know, they've been and spoken to someone, it's just making sure that somebody's then checking in with them to make sure they're all right, because we know, I've never had, touch wood, terrible mental health stage. Some of you might think I'm a bit cuckoo sometimes, but I've been very lucky. But you know, 1 minute you can be fine, I understand, with if you've got a mental health issue, and the next minute something can trigger you off, and you know you're really down, and all sorts of things can happen. So I think, you know, especially in rural areas, and you talk about centralising something in Boston. Boston is a hell of a long way from Mablethorpe or Sutton-on-Sea or in the centre of East Lindsey. So, you know, I do think, you know, sometimes we do have to have just smaller hubs across the county. And I know they take a lot of funding, but it is about local people being able to have that local service, because a lot of people don't have a car, perhaps. You know, they rely on a bus service. And I know people from Mablethorpe struggle to get to Louth. Well, for us who've got a car, that's not a problem, but it is if you've got an irregular bus service. So that's all I would plead, that actually in this review and all the work you're doing, that actually we do get the right services in everywhere across the county, but particularly in rural areas, because people do have a problem moving around.
Yeah, thank you. It's an interesting point you raised there about Louth, because we are looking at a hub and spoke model where we've got a community hub in Louth, but Mablethorpe, as you say, is an exceptionally long distance. So we are working with a GP practice in Mablethorpe to ensure that we've got coverage there, not just because it's better access for the service users, but it saves so much on staff time, not travelling around as well. So in terms of the community teams, I have to say that it's always a balance between quality, access and finance. We do have to centralise some services to ensure that we get better quality. And we do have something called ACOMS accreditation for our community teams, which is a mark of quality. But you're absolutely right. That's the whole point of the community transformation. It's ensuring there isn't a cliff edge where you might get that crisis and intensive treatment and then it stops. So this is about working with voluntary sector, working with general practice in terms of what does that universal, no wrong door service look like going forward. And like I say, again, I'm happy to bring back when we're a bit further ahead in terms of the pilot rollout. Thank you.
Thank you, Sarah. I've got Glenn, then Councillor Wright, please. Glenn.
Thank you, Chair. Different chair this time. So, a couple of observations and a question. I suppose the first one is, and we're all running organisations that are pressured at the moment and yet have ambitions for the next 1 to 3 years to be in a different place. I think it would be quite useful to tease out, so what should we look for that's different and better in 3 years from now, given all the exercises that we're undertaking? And I think that applies equally in the mental health field, Sarah. So think about reduced inpatient facilities out of county, retention of staff, employment of people with mental health issues, given that employability for people with profound disabilities and mental health is a national issue as much as it is local, and it's certainly probably going to get harder. And then the other couple of thoughts was digital technology. Most colleagues making a presentation about their organisation, myself included, feel obliged to say something about digital nowadays. And I couldn't see the word, and that might be because you're actually doing more than I am. Or you might be being honest and saying, actually, we haven't got there yet.
Okay, if I pick up the point about the priorities and what good looks like in 3 years, so that's what's currently being built up in terms of the Mental Health, Learning Disabilities and Autism Partnership Group. It's coming to the next meeting in terms of the early draft of those 3-year priorities, and that's been primary care, police colleagues, local authority colleagues, the CCG, and in terms of the prevention concordat as well as part of that, you know, what we're actually doing to make sure that people don't get acutely unwell as much as we can further on down the pathway. So watch this space on that one. In terms of digital, it's an interesting reflection. I think it's so embedded in the organisation that it's remiss of me not to talk about it. We were one of the top 10 mental health trusts to use Microsoft Teams through the pandemic. So what we're looking at, we first started out with a digital first but not digital only approach. You know, when infection rates were exceptionally high. We've moved now to a hybrid model, which is very risk-based in terms of a digital assessment isn't appropriate for everybody. If you're in an area that hasn't got great broadband coverage, if we think that the patient is acutely unwell and needs face-to-face, then we're making sure that that is a face-to-face assessment or follow-up treatment appointment. But for something like improving access to psychological therapies, you know, low-level, mild to moderate depression and anxiety, absolutely. It's almost, I think it's something like 95% of interventions now are face-to-face, digital as opposed to face-to-face. But for some people, what we're seeing a bit of a challenge with is the group work, where some people's recovery is really improved by getting together as a group, and it just doesn't work sometimes on Teams. So what we're trying to do is make sure that we're risk assessing each of those therapy groups and making sure that we do it in a safe way, allow people to come back together again. So yeah, sorry I missed that one out. Oh, my head of digital never forgive me for that. Thank you.
Thank you, Sarah. Thank you, Glenn. Councillor Wright.
Thanks, Chair. It follows on from the questions, really, Sarah. I mean, people have highlighted the fact that we need some of these care and systems in place, and we need them yesterday, not in 3 years' time. But, you know, the slide on page 39 has got some really good initiatives on there. You mentioned a £7 million spend, which won't really go that far. So what realistically is a timescale we can expect to see those sorts of initiatives widespread across the county and not just centred in some areas, because, as you've heard, there's lots of places that are really desperate that don't quite fit into a hub and spoke, and we need to get out there. And let's face it, some of these are partnership work in more than direct spend. So what's a realistic timescale?
Yeah, so we've already got the nightlight cafes and community hubs set up in place. In terms of the mental health helpline, obviously that's a universal offer, 24/7 for everybody. In terms of the pilots, so we had Lincoln, Boston and Gainsborough as sort of the first pilots to go ahead, and we're rolling out the next 6 now as well, so it'll be sort of 9 areas fully rolled out. And again, I'm happy to provide more detail at the next Health and Wellbeing Board in terms of exactly where we are on those pilots. So personality and complex trauma support, for example, that's currently a postcode lottery where we're recruiting to fill and make sure that it's across the whole of Lincolnshire. But at the minute, it's only Lincoln and Boston area that we've got that service in place. So I'm more than happy to bring more detail in terms of where we are on each of these to the next Health and Wellbeing Board, if that would be helpful.
Okay, and Councillor Kendrick, please.
Thanks, Chairman, for letting me come back. I was very interested in what's just been said. I think it might be useful for members to have some information to where we can refer people, such as the nighttime cafes and the helplines. I mean, the helplines are a great thing. I can see that, because mental health issues aren't Monday to Friday, 9 to 5, as we all know. And I think it's fantastic that we've got that sort of thing coming in. But I think it might be helpful to members if we could have some basic information about the contact numbers and details of locality of things where we can refer constituents or families to, so they can get help straight away.
Brilliant.
Thanks, Chairman.
Yeah, I'll do that, definitely. Thank you.
Thank you, Sarah. And Councillor Gray, please.
Thank you, John. With regard to children and young people and the mental health and eating disorders, you mentioned that some of the 6-week targets are not being met, but you didn't say how many are over target, so I was just interested in that. Just going on from Councillor Kendrick, nightlight cafes, what time are they open till? Because I know a lot of people struggle out of hours, so it'd be interesting to know what time they're open to. And just a point of reference regarding digital, there's a number of good neighbour schemes in the county. There's one in particular called Steps to the Future. It's purely online. They have dozens and dozens of service users that are referred to them by social prescribers. I know, because I've attended some of their sessions, to observe that many of those people have mental health issues. So in the voluntary sector, there is some great work happening here that helps people who are struggling. So I think we just have to remember that a lot of good work is being done in the voluntary sector. Thank you.
Excellent, thank you. So in terms of the children and young people's eating disorders, so in terms of the numbers where we've got people on the waiting list, it's 13. So if that helps give a bit of context to the amount of people who are waiting. And where we do breach, it does tend to be 1 or 2 days as opposed to actually a really extensive wait. But I guess what I'm saying to the board is this is where we are as at June, and if it continues to increase, then we will see that get worse. So we're really desperate to get those extra staff in to make sure that we can deal with that capacity. In terms of the nightlight cafes, I'll include that in the information that's circulated, because it is different from each of the community hubs. So I'll get that circulated. An excellent point about voluntary sector. And that's the whole point of the community transformation, is we can't recruit enough qualified nurses to do it all, and they don't need to do it all. We need to rely on our community assets to hold people safe in their communities where it's appropriate to do so. Thank you.
Okay, any other questions? Sarah, look, thanks for that. Great presentation and discussion. Would the board be comfortable if I just discussed with the proper chair whether we want to bring this back either at the next meeting or maybe the meeting after that, just dependent on other business that might be coming forward. But either way, Sarah, I think we welcome a return presentation in the fairly near future. And I think if I could just say that one of the frustrations I think we share, particularly around the helplines, but maybe it's around the nightlight service as well, is I do pick up a lot from within the NHS of people saying we don't know where to go for support, and these services are out there already. So I think it's going to be a constant push, isn't it, in terms of drawing people's attention to these services. The 24-hour helplines, the two of them, I think provide great support, and we need to make sure that as many people as possible are aware of those, and we'll keep pushing on that. And just by the way, well done for being shortlisted in the Health Service Journal Mental Health Trust of the Year Awards, and I'm sure we'll all wish you well in that venture. Thank you, Sarah. Shall we move on then, everybody, please, to the next item, 6D, the Joint Strategic Asset Assessment Update. Derek, is this you? Over to you then.
It is, Chair. I'll introduce it, and then I think we've got Sam Neal online, potentially with Sean from my team, just to give a bit more detail. It actually fits really well with Sarah's presentation and also Councillor Gray's question about voluntary and community sector. The board will remember that we have a statutory duty to produce a joint strategic needs assessment that outlines what the needs of the population are, different to what the demands of the population are, but what the actual needs of the population are. And we do that, well, we've got an ongoing process basically, and we're looking to change that into quite an automated process as well. It was one of the things that I wanted to do when I came to Lincolnshire is develop the other side of the equation, because it's really important that we understand what the needs of the people of Lincolnshire are, but we also shouldn't do that in isolation and think we've got to fill all of those needs ourselves, because there's a huge amount of support, whether they're voluntary community groups, whether it's just family and friends support, carer support, and we saw it through the COVID pandemic, the number of people who came forwards to offer to just go and get some shopping for a neighbour who's maybe isolating or clinically vulnerable and was staying away from people. So the Joint Strategic Assets Assessment is basically to do a couple of things. One, to understand the physical assets we've got across the county, because we've talked previously, and in fact we were one of the case studies in the Chief Medical Officer's report about rural and coastal communities. We're a big old place, but we've got lots of buildings and physical assets between the county council, district councils, NHS partners and other public sector organisations, and there's an opportunity to use those differently and share them. So that's point one. And then point two is we need to understand what's already out there in terms of the people assets, the support that is already there, that either some of us know a little bit about, but most of us don't know anything about, or in fact none of us around this, in this chamber know anything about, but is fundamental to helping the health and well-being of the people of Lincolnshire. So that's the point of the Joint Strategic Asset Assessment. It's not a small undertaking, as you can imagine from that description, and we've moved it on quite a lot, but obviously COVID has slowed us down to some extent. I think Sam's just going to give a quick overview of where we're up to on this and some of the key tools that we've got.
Great. Hi, Sam. We can't quite hear you. You I hate to ask you. No, I don't think she's on mute. No. I can hear her. I can't hear her mouthing, I'm not on mute. Okay. Just bear with us, see if there's anything we can do at this end. Just hang in there, Sam, please. Is that off and then on again, is it? Okay, I can see you, Sam, thanks.
So,
Is that working?
Oh.
Does that work at all?
Yeah.
hey,
Keith
hey,
Robinson,
up
at his
there
best,
for thinking,
yes.
down there for dancing.
Right, okay then.
I can't hear anything on my system now. I have. It's just coming in.
Yeah, you're getting feedback, but we can hear you now, Sam, if you can hear us.
Yes. Yeah.
Do you want to just pull out the key points? Oh, I've lost her. Forget it.
Look.
That nearly worked, didn't it?
Let's move to Plan B then, Derek. Would you?
Plan B. I've done the introduction. So this is really about trying to balance off the needs with what assets we've already got, so that we can understand how and where we deliver services, but not in splendid isolation, which I think was the key point of Councillor Gray previously from a mental wellbeing perspective. It has been obviously impacted upon by COVID in terms of trying to get that asset assessment done. I won't go through all of the details here, because there's lots of technical arguments about what a community asset is. If you're a sociologist, we could get lost in that debate. But in a nutshell, we've got now a link to our buildings and our core assets, and we're also starting to, and in fact we've got quite a lot of community assets already on our key platform. And the key platform is Connect to Support, which we've spoken about before in the Health and Wellbeing Board. I think one of the key challenges that's come up from this is that there are lots of different platforms with lots of different assets available out there, because Mental Health Trust and Sarah have some assets. Obviously we've got NHS Direct, 111, 999, all of these different assets. So it isn't going to be a perfect system. But what we've put onto Connect to Support in terms of the physical assets, and we've been using a lot of this through COVID response, is, I'm sort of in two minds about saying this. The first time you go in and you look at the physical assets, you just get a list of pubs. But actually it is the pubs in a large rural dispersed community like Lincolnshire that are often a really good community asset, if those pubs can be used for broader facilities. And that's what we're doing with Connect to Support. So that's one of the key parts. And in the paper, if you click on the venues, buildings and facilities, you can see what we've already got on there. I think it's really important as well that everybody in the board and your organisations are aware of this, because community physical assets and community-based people assets, whether that's voluntary or community groups or whether it's individuals, you can put your information onto Connect to Support, and then Connect to Support will allow members of the public just to go in and say, I'm interested in, I don't know, it might be a walking club, it might be a knitting club, it might be, I'm a bit lonely actually, what's around me? And then Connect to Support will start to pull all those areas and show it on a map. You can then click through and find out the details of when that walking group is or when that knitting group is, and then start to connect yourself up. And I think that's one of the key areas that we're looking at. We're looking at it through adult and children's social care, for example. Rather than being sort of a negative deficit model, this is about an asset model. This is about what can we do to help ourselves, what can we do to connect ourselves into existing community resources. We were talking about it this morning actually at the Lincolnshire FC Foundation, which is the charitable arm of the football club, launch. One of the key things that people have discovered, I think, or rediscovered through COVID is that sense of community, is a sense of looking after each other. And we see really the Joint Strategic Asset Assessment as a way to facilitate that. It doesn't do it. It's a bit of a technological solution, but it connects up people with other people or people with facilities. I think that's really the key point. It's the first phase of our approach to Joint Strategic Asset Assessment. It is a technical solution. but it's something that we didn't have before. The more it is used, the more it will become embedded in everybody's day-to-day, whether you're just a member of the community or whether you're actually a practitioner, if you're a GP, if you're a social prescriber in primary care. We see Connect to Support as a key way to help for people who come through our NHS services who might need some clinical support but often need connecting with other people in those communities. And Connect to Support and the Joint Strategic Asset Assessment is a way for us to do that. So work in progress. Happy to take, not detailed questions because I haven't got those, that's where Sam could answer, but any key points that people want to raise. But the more we use it, the better it will get.
Thank you, Derek. Well done. Councillor Marfleet, please.
Thank you. Yes, I did go on and have a look, and I found my pub in my village. But I think my reservation of this is that if we're not careful, it gets you're taking on a beast when you start trying to map everything, and that would be my my worrying concern. Having read through your document, there is a sense of well, the other day, what was it, Saturday, I went on a bike ride and I picked up from Doddington Hall and cycled into Lincoln along the old Skellingthorpe Railway. And it's great. And while I was doing that, I was thinking, there are so many great areas, and I've done it around the country as well throughout the summer, and actually people are using those assets tremendously for dog walking, for cycling, for kids, for family time, the whole lot. And I'm sort of sat there going, have we really mapped out where these assets really are? And I'm reading this thinking, well, we're talking about it, which is good. And then I'm thinking, but where we actually perhaps need to work on is master plans where we can connect them more together. And I'm thinking this is sort of a bit of an approach to that in some sense. And then I start looking through it and I think you really perhaps... You're right, I want to know where the knitting club is. I want to know where this club is and that. And not that I do want to get into knitting, but you're right, that's great. And especially for the rural areas, we struggle to get that. And it is great when you can do that. But if we don't watch it, you'll lose that info in all the other info. And if we don't watch it, I don't think this website's brilliant enough to do what you want to do in terms of the mechanics of the website itself. And I think if you're not careful, I think you're going to, in effect, we could drown in this. And I would say my view would be pick out some things that we really want to promote first and really get the connectivity going. Ironically, pubs, I question their community asset. And the only reason why I say that is, as much as I like going into a pub, actually most older people often don't like the pub scene, even if it's for coffee. And the irony, from here back to Market Raisins, a pub that's failed and failed and failed, and they've turned it into a coffee house, and it's so successful because it's a coffee house and not a pub. And so I think, anyway, I've perhaps said enough, but I think direction and focus is really what I would say is really key to make this successful. Thank you.
I completely accept that's an approach and that's an argument. I think this is one of those areas where perfect is going to be the enemy of the good. And what we want to do is have something that is specifically for the people of Lincolnshire in this space. And Connect Sport, again, I agree, it's not all singing, all dancing, but we haven't got the budget of, you know, Google or Facebook. We're not going to be able to do that. And there are lots of different sources, and people get their information from lots of different sources. This is basically individuals and communities putting the information on and then being able to access it. So I don't disagree, I think, with anything you've said, Councillor Marfleet. I just think there is, we as a board agreed a strategic approach to do something. This is where we're up to. We'll keep iterating it. We'll keep developing it. The more it is used, the better it will become. And we will need to connect into things like from a physical activity perspective, there's a huge range of Sport England facilities that we're going to have to cross-link. Doesn't make sense us putting them all in again. We'll just need to have a cross-reference, and things like that are just going to keep coming up as we go.
Thank you. So I've got Councillor Wright, and then Glenn, and then Emma, please.
Thank you, Chair. On the cross-linking, Derek, that's the point, because I think it was the last meeting, it's been raised before, that the district councils actually have lists of community assets, this side of thing. Unfortunately, when I was discussing this with everybody, that whoever has found whatever email addresses to talk to the district, there's some pretty obscure ones that are being contacted. So there's a new list either being sent through to DEM services here today, or it's on its way, and we'd ask that perhaps it could be recommunicated, because the people that have been contacted simply aren't the ones that are connected to this sort of project.
Thank you, Chair. I'd just like to compliment Derek and his team for moving into this space. It's a very, very unusual step in councils and public health and wellbeing boards to actually look at a, as it were, asset-based model rather than deficit. So I just think that's really important not to lose sight of. In my view, it's the right thing to do. If we give this oxygen, particularly the website, it'll grow, it'll thrive. It doesn't have to be like Google for it to be a benefit in Lincolnshire. And I suppose the only other point would be, although, as you can tell, I don't have a particular interest in this, hairdressers in other parts of the country have, not everybody has to agree with me on that one, but hairdressers in Liverpool, for example, have been used multiple times by NHS colleagues there to, as it were, improve take-up rates of various screening regimes. So there are, and also they're probably one of the key retail points of reference that have survived almost anywhere, to the, as it were, exclusion of things like the post office and pubs which haven't.
Great points. Thanks, Glenn. I agree. We've got to make the best of what we've got and grow from the assets we have, rather than describe those that we haven't got. Really, that's the best way forward, I think. Derek, do you want to come back, and then I'll bring Emma in?
Yeah, I was just to say, really good point. We've, hairdressers, taxi drivers, pharmacy, delivery people, they're all key connectors. We've got another workshop planned to look at what else, and as I said, this is going to be an iterative process, and we'll just keep trying to add to it to make it more and more useful. But yeah, really good point. Podiatrists also, because you've literally got somebody by the foot at that point, and there's quite a lot of evidence that they are very good health navigators and health communicators.
Thanks, Derek. And then Emma, please.
Thanks, Chairman. Just one comment and one question. Comment in terms of the point actually around physical activity. We're working really closely with the connector support team to make sure that we integrate all of the facilities, the open spaces, the places where people can go and do activities to feed into Let's Move Lincolnshire, which is a currently work in progress, a platform that's going to go live at the end of October. So actually the data that's being inputted into connector support, we can take and amplify that from the perspective of physical activity, and we're using user groups from across Lincolnshire to help us shape how they're going to navigate around that data, how they want to interact with the data, how they want to be able to find out places and opportunities for them to be more active. So actually, whilst I recognise there's a huge amount of work going into connector support, we're trying not to duplicate that data, and that's been a really helpful way for us to tap into some of the facilities and the activities that are available across the county. My question, I think, is around connector support and who's using the platform and what kind of data you have in terms of visitors to the platform. What are they looking for? How are they engaging with it? And how many people are engaging with it?
Now, you see, that's a detailed question that unfortunately the technology has failed me on. I do know that we are capturing all of those data and that information as much as you can, because obviously you get an IP addresses and stuff like that. I don't know the detail. Sam's just texted me through here. So we've got the web analytics. So we'll pull that together maybe for the next time we come back and obviously share, because what we don't want this to do, and we've not spoken about it, we don't want it just to be another source for the affluent middle classes who could find it from other sources. We want to target this at those groups who maybe wouldn't get the information from somewhere else, and try to support those individuals, which is where Glenn's point about different approaches is really important.
Yeah, okay, any other questions? Derek, well done. We'll come back on Emma's question. I thought it was spot on. There's also a bit of a resonance for me about the conversation we had with Sarah about how we make sure that people we serve are aware of the assets we've got, be they mental health helpline or other community assets as well. So I'm sure we'll be coming back to this on an ongoing basis. But just for now, thank you very much. Right, okay. Shall we move on then? So that's all of the items for discussion. So we have an information item from Tracy Perrett. Is that just for information and for noting, colleagues? Okay. Are we happy to note it? I'll take that as a yes. Do we have to vote on that? Okay then, shall we move on? Action log of previous decisions then. So again, is this just for our information, I think, isn't it? Again, just for noting. Okay, perfect. And then we have our forward plan, please. That's on pages 63 and 64. Again, just for noting, and as I said earlier, we'll pick up the issue of when Sarah might just come back with an update on those mental health points as part of this. Councillor Wright, please.
Thanks, Sean. I know you've got it for noting, but the question is, can an update on the Let's Move initiative from Active Lincolnshire be added to the forward plan?
Thank you. The answer is yes, it can.
Yeah, really happy to do that. It'd be very helpful actually to share it with this forum.
That's great, thank you, Emma. Would that be something we could bring back perhaps next time?
Yeah, absolutely, yeah.
Perfect, thank you. Everybody okay with that? And then, okay, I think that's it. When will we be meeting again? 7th of December. Okay, so we shall look forward to seeing you all again then. Thank you for your help in actually finishing the meeting. What's that, about 7 minutes early? Thank you. Okay, great to see you all. Bye for now.